Pulse Talk, bringing insights into health and wellness with your hosts, Christine and Alex.
Okay, imagine this scenario. You just had a heart procedure, maybe a stent put in, right? To keep everything flowing. Your doctor prescribes Clopidogrel. It's a blood thinner, supposed to stop dangerous clots. You take it every day, like clockwork. But here's the kicker. For some people, maybe quite a few people, that pill, it barely does anything at all. So why? Why does the exact same medicine work wonders for one person and fall flat for another? Especially with something so vital as heart health. That's really the puzzle we're diving into today. We're looking at sources exploring, well, Clopidogrel, genetics, and heart health. Our mission here is to sort of unpack how your genes and medications interact. Give you a shortcut, maybe, to understanding why your unique body blueprint matters for common drugs. We want to break down how your DNA can actually influence whether a crucial medicine works and, what you might be able to do about it. All right, so let's talk about Clopidogrel first. As I said, it's super common, prescribed a lot after things like getting a stent. Its main job is to stop platelets, those little sticky cells in your blood, from clumping up and forming clots. Really important to prevent blockages, heart attacks, strokes. Basically, an anti-clogging agent for your arteries. But, okay, here's where it gets really interesting. The Clopidogrel pill, you actually swallow. It isn't active yet. It's what scientists call a prodrug. Yeah, think of it like getting flat-pack furniture. Like that bookshelf you ordered. You get the box. It has all the pieces, the screws, the little Allen keys. It looks like it could be a bookshelf, but you can't put books on it yet, right? It's just parts. Your body, specifically your liver, acts like the instruction manual and the tools needed to assemble it. It has to put those parts together to make the actual functional bookshelf, or in this case, the active drug. And sometimes drugs are designed this way on purpose, maybe for better absorption or fewer side effects initially. But the point is, without that assembly step, the bookshelf is useless.
That's a really good way to put it. And that assembly process, it really hinges on one specific enzyme in the liver. It's called CYP2C19. That's CYP2C19. It's part of a big family of enzymes, the cytochrome P450s, which are basically the liver's main drug processing machinery. For Clopidogrel, CYP2C19 is like the specialist worker on the assembly line. Its job is specifically to take those Clopidogrel parts and turn them into the active form that stops platelets sticking together. And here's the fascinating link. Our genes, our DNA, provide the instructions, the blueprint for how well that CYP2C19 enzyme, that specialist worker, actually functions. Everyone's blueprint is slightly different. It's not just about having the enzyme. It's about how effective it is based on those genetic instructions. So if your personal genetic blueprint has certain variations, certain, let's say, typos in the instructions for the CYP2C19 gene, well, your assembly team might work very differently. Some genetic blueprints lead to what we call poor metabolizers. Their CYP2C19 enzyme might be slower, or maybe they don't make as much of it. Imagine their assembly worker is just really slow, or maybe they keep losing their tools, or the instructions are smudged. The furniture, the Clopidogrel, never gets properly assembled. It stays inert.
Wow, okay, so the drug is there, but the body just can't flip the on switch because the genetic instructions for the switch mechanism aren't quite right, and the consequences, you said they're serious.
They really are. Studies consistently show these poor metabolizers can have something like a 3 to 4 times higher risk of serious clotting events, like a heart attack or stroke after getting a stent, even though they're taking the Clopidogrel.
3 to 4 times higher. That's huge. That's a massive difference directly linked to their genes. The very medicine meant to protect them isn't working effectively.
Exactly. And it's not incredibly rare either. Depending on ancestry, the percentage varies. But for instance, in some East Asian populations, it can be up to 30% or even more who are poor metabolizers. But these variants exist everywhere. And it's not just on or off. There are intermediate metabolizers too. Their assembly line is sluggish, but not completely stopped. It's a spectrum.
Okay, so there's a risk of it not working well enough.
Right. But then there's the other side of the coin. Some genetic blueprints create ultra-rapid metabolizers. Their assembly team is working overtime, super fast, activating the drug really, really quickly.
That sounds like it should be good now. More active drug.
You'd think so, but it actually creates a different risk. Too much active drug too quickly means the blood gets thinned too much. So their risk isn't clotting, it's bleeding. Uncontrolled bleeding can be just as dangerous.
Ah, okay, so the genetics can make it either not work enough, leading to clots, or work too well, leading to bleeding. It's a delicate balance.
Precisely. It's all down to how effectively that CYP2C19 enzyme functions based on your genetic code.
So what does this all mean for you listening? It really drives home that your genes can play a surprisingly big role in how medications affect you.
It absolutely does, and it raises a really practical question. If you're prescribed clopidogrel, what can you do? Well, one thing is to talk to your doctor. Ask if genetic testing for CYP2C19 is available, or if it makes sense for your situation. It's not always standard practice yet, but the conversation is important.
Are there specific situations where it's more important?
Yes, definitely. Say if you've had clots before, especially while on a blood thinner, that's a red flag, or if you have a really strong family history of heart disease or clotting issues. In those cases, knowing your CYP2C19 status could be particularly valuable information for guiding your treatment. There are clinical guidelines now that help doctors decide how to act on these genetic results.
So there are guidelines. It's not just theoretical.
Not at all. This kind of personalized insight, understanding how your specific genes affect how you respond to a drug, it's becoming more and more central to good medical care. Sometimes, knowing this allows doctors to maybe adjust the dose, or more often, switch you to a different antiplatelet drug entirely, one that doesn't rely so heavily on CYP2C19 activation. And that switch can literally be life-saving, preventing another heart attack or stroke. It's about tailoring the therapy.
Moving away from that one-size-fits-all approach?
Exactly. It's the core idea behind pharmacogenomics, using genetic information to optimize drug therapy for the individual. And sometimes doctors might also use tests that directly measure platelet function, how sticky your platelets are while you're on the drug. That gives a real-time picture that complements the genetic info.
Okay, got it. So the big takeaway seems pretty clear. Clopidogrel can be a fantastic heart-protecting drug, but only if your body has the right genetic tools to activate it properly. Knowing your CYP2C19 status, or even just having that conversation with your doctor, could be really key to making sure your medication is actually doing the job it's supposed to do. It gives you a bit more control, more agency in your own health. It really makes you think, doesn't it? But all the other medications out there, how many are affected by our unique genetic codes in ways we just don't routinely check for yet? It points towards a future where medicine is much more precise, much more tailored to us as individuals. Next time, we're going to look at something maybe even more relatable day to day. Painkillers. Why does the same pill work like magic for one person and do almost nothing for someone else? Turns out your DNA has a lot to say about that too. Join us then for another deep dive.